So as you guys are already aware, we're in an extremely highly regulated space in a state that pays a lot of attention to this stuff, and now we're layering on a new treatment modality. So as you can imagine, there's a whole slew of new regulatory issues we have to consider. Since we only have 10, 15 minutes together, we'll go through kind of some high-level ones. We'll talk a little bit about licensure. We'll talk a little bit about credentialing, about prescribing, and medical device issues, and then we'll touch a little bit on reimbursement. So to start with, a lot of practitioners call and ask, what is telemedicine and when is it permitted in the state? And these are excerpts from New York State public health law. Starting at the bottom, telemedicine, which is a subset. The key, which Jeremy referenced again, is that it's synchronous two-way electronic audio-visual communications. Means it's got to be real-time, it's got to be audio-visual. And this is telemedicine just refers to the rendering of professional services, specifically the assessment, diagnosis, and treatment of a patient, where the provider is in one place and the patient is in another. Telehealth is a broader term, and it also includes education, care management, self-management, and interestingly, specifically, the state says that makes clear that telehealth does not include, and this is key, does not include audio-only communications, doesn't include texting only, doesn't include faxes, unless that's in conjunction with another acceptable telehealth modality. All right, so getting to licensure. As Jeremy referenced, the key is the place of service, and the place of service is where the patient is located. So the provider's got to comply with whatever the law of the land is, again, the law of the land being where the patient's located. That, of course, means that the provider has to be licensed in the state where the patient's located. That's very frustrating to a lot of my telehealth clients that want to be in all 50 states because it requires having providers that are licensed in all 50 states and making sure that the right provider is matched up with the right patient. There are state-by-state exceptions. Some states do permit physician-to-physician consulting. Some states do permit slight cross-border treatment. There's also, some of you may be familiar, there's an interstate compact out in the Midwest where there's reciprocity, and if you have a license in one state, it's acceptable in another, and that's catching on slowly, but hasn't made its way here yet. Generally, as good practice, people often ask other things, and this goes a little bit beyond telehealth, but what if I'm treating a patient and then the patient is a snowbird and goes back to Florida, or is a student and goes back to school? And the general rule of thumb is that if you're following up, whether it's by phone, by email, and it relates to the same concern that you saw the patient for in the state where you're licensed, okay. But if it's moving on to a new issue, then you really have to respect the licensure rules. Other times people call and ask and they say, look, we see all these companies where you can reach out and you can get a physician in Europe and someone will answer your question in 24 hours. One is called First Derm, where you can kind of take a picture of a physician can take a picture, or a patient, of their derm issue, send it in, and within 24 hours some European doctor will spit back a diagnosis. The key to most of these companies and the way they try and structure themselves is that they say that they're just giving information. They're not giving medical advice. They go a step further to bolster this argument. Oftentimes they will de-identify both the patient and the physician. So the physician that's viewing the slide doesn't know anything about the patient, and the information that comes back doesn't include anything about the physician. That's just one way some folks get around stuff. So oftentimes when we're getting these questions, how do other people do it? Sometimes this is one of the methods they use. The other question we get a lot is how does this apply to mid-level providers? And the answer is all the same regulations that apply. So licensure where the state is, where the patient's located, all the same scope of practice issues apply. Any physician collaboration or supervision that's required is still required when rendering service this way. In terms of credentialing and privileging, there's always the general rule that providers practicing in facilities have to be credentialed by those facilities. New York does permit delegated credentialing, meaning the sharing of credentialing and verification paperwork. So the distant site can provide kind of the primary source, copies of the medical license and that such through a delegated credentialing agreement. But the end facility still has to determine in the end and put the stamp on whether that provider is acceptable to them. The Joint Commission and CMS also permit credentialing by proxy, privileging by proxy, but there's certain requirements there. And in that case, the distant site hospital, for example, has to participate in Medicare. The The provider obviously has to be privileged by that distant site hospital. The distant site hospital has to provide a current list of all the privileges of that provider to the originating site. Those two facilities have to share information about the provider and also share information about adverse events to the extent any occurred. Another thing that's important is to check out your bylaws. You have to ensure that you're set up appropriately to do that. One example is oftentimes bylaws require in order to privilege a physician, that physician have a minimum number of admissions, for example. That's not going to work for a telehealth provider, so oftentimes you want to put in kind of separate credentialing levels and privileging levels for telehealth providers. In terms of prescribing, which Jeremy touched on a little bit, we have both state and federal laws to deal with. Jeremy talked a little bit about the Ryan-Haight Act and how that requires a practitioner to conduct an in-person visit prior to prescribing controlled substances. New York State has a similar law, a regulation actually, that no controlled substance can be provided without a, quote, prior examination. There's only one piece of guidance. In 2007, DOH put out a practitioner update that said that means physical exam. So there needs to be an in-person physical exam prior to prescribing controlled substances. Notably, there are exceptions to the Ryan-Haight Act, including that if the patient is in a hospital or clinic, and then it's being prescribed via telemedicine, but the patient's sitting in a hospital or clinic, that's one exception to Ryan-Haight. But again, that doesn't help you under the New York State guidelines. But things are loosening up, as Jeremy pointed out, because people are trying to push this modality just because it makes care more and more available. This kind of shows you, I mean, it's an embodiment of how much regulation there is. These are all the folks that come into play. Obviously, you have New York State DOH, you have New York State Department of Education, who deals with licensure stuff, CMS, the FCC and the FDA have both come together through an MOU to regulate telemedicine together. In particular, there's the Center for Devices and Radiological Health is the FDA agency that ensures safety and effectiveness of telehealth. The key through all this that we kind of haven't talked about is there's the devices involved, right? Whether it's an iPhone or some other mechanism. And the FDA regulates medical devices. The definition for medical device is very, very broad. I'll read you pieces of excerpts. It's any instrument, apparatus, implement, machine, contrivance, implant, in vitro reagent, or similar or related article intended for use of diagnosis of disease or other conditions, or the cure, mitigation, treatment, or prevention of disease in man or animals intended to affect any structure. It goes on and on and on. Almost everything can be deemed a medical device. FDA looks at that and divides medical devices into 3 classes, depending on potential for harm. Class 1, think tongue depressor. That's a medical device. The FDA doesn't do much with it. Class 3 on the end of the spectrum, a replacement valve, a heart valve. Most things are going to fall into Class 2, which still require FDA review. An example is also, mobile applications, right? Mobile applications are medical devices. And they're subject to FDA regs. And to the extent they assist with diagnosis or treatment recommendations, that's included. FDA doesn't tend to regulate, though it's still a medical device, apps that help manage health, organize and track information, document or communicate information, or perform simple calculations like what your respiratory rate is or what your pulse is. Also, what's not deemed medical device are things like reference materials or educational tools or things of that nature. All right. Moving on to reimbursement real quick. Until recently, as Jeremy was pointing out, it was just hard to get reimbursed, and that's because most things follow Medicare, and Medicare is very stringent in this regard. That didn't mean that folks weren't adopting telehealth. They were, but just not as a revenue generator, more as for continuity of care or for cost savings. But that's all slowly following, and things are loosening up. Many of you may be aware of the 2016 New York Parity Act. And that requires both commercial insurers and Medicaid in New York State to reimburse for telehealth services to the extent they would have reimbursed had the service been offered in a brick and mortar site. Now, importantly, again, this only applies to commercial payers and Medicaid, and it only applies to the extent the patient is in network. So out-of-network services don't have to be covered, though we are seeing payers reimburse at times, but they're not legally required to. We're also seeing an expansion in Medicaid reimbursement. Just recently, Medicaid expanded to reimbursing for telehealth that's done when the patient is in the home. And then as Jeremy alluded to, there's reimbursement rules are changing for Medicare, which is really the important piece. Again, to go a little bit further into what Jeremy was saying, Medicare requires that the patient be at an originating site. That's pretty much in a rural or a site where there, or a zip code where there's a provider shortage. And then it only applies to the extent the patient is in certain places. You'll know patient being at home is not included. Patient has to be at a doctor's office, hospital, skilled nursing facility, et cetera, et cetera. It's also limited to the type of provider. So the type of provider is limited to that list on the right, physicians, NPs, PAs, so on and so forth. There's a link here. I'm not sure if you guys are getting these materials that you can look up whether a location is in a HPSA or not. But most importantly, recently proposed rules came out by CMS. Right now we're in the comment stage, so folks have put in their comments. In another, I think, month or two, we're going to find out what they accepted and what they didn't accept. But Administrator Verma has committed over and over publicly that she intends to expand reimbursement. Most of these expansions are actually, it's interesting, the whole originating site thing is for telehealth services. Most of these in the new physician fee schedule, these proposed new types of services, the way they're getting around the originating site requirement is that they're making these separate codes. So these won't be telehealth services, so they won't be required to be, the patient won't be required to be in a rural area or where there's a shortage. So there's going to be virtual check-ins potentially. Asynchronous images, meaning the store and forward, which Medicare currently doesn't reimburse for, peer-to-peer consultation. The expansion of the Medicare telehealth services are actually an expansion of the current telehealth codes, so those will still require that you be an originating site. And then there's an expansion of remote patient monitoring, because there's so many devices that can now help folks get information that they're looking to pay for it also. So that's where we are.